seems so crowded, I guess it's really good. And then you don't even have people. You don't take over to okay. But wow, I don't know how we're gonna take exams in here. It's very easy to talk about one another, just saying. But anyways, right, so hopefully today we will finish our discussion of conventional antineoplastic agents and venture into the exciting land of targeted antineoplastic agents, and then the last packet, antineoplastic drugs, part 3, finishes up with immunotherapy, CAR T therapy, things like that. I think I'll save that for the next meeting. Reminder, don't come on Monday. Monday is a holiday. Monday is President's Day. Okay, so we spent a lot of time talking about alkylating agents, which were the first conventional anti-cancer drug. And then the second, I don't know if we actually did this, we were somewhere close to here, right, in terms of what slide we were on. The next type of conventional antineoplastic drug therapy, of course, are the anti-metabolites. Just let's get back into the swing of things, review and alkylating agents, cyclophosphamide, things like that. The alkylating agents are considered non-cell cycle specific agents, whereas the antimetabolites are considered cell cycle specific agents, and they basically target the S phase of the cell cycle. They've been very good for the leukemias. I think this is the regular slide we were on. Right, so there are a bunch of them that we're going to learn about. Important, interesting factoid, listen up, you'll all appreciate this. The last slide of the third packet, the last slide of antineoplastic drugs part 3 has a list of the drugs that are the important ones to know in terms of assessments. Because we're mentioning a lot of drugs, we're throwing names of a lot of drugs out there. Yes, as we go through, I have tried to highlight the drugs that I think are important in red font. But if you want to take a peek ahead, that packet is already posted on Canvas. So if you want to look at the last slide of part 3 of antineoplastic drugs, you know, if you're curious, you know, how much time should I spend studying on drug X? Whoops, it's on the list, or oh, it's not on the list. Okay. Antimetabolite in the sense that these drugs are mimics of folic acid metabolites. What does folic acid have to do with cancer, drug therapy, and all of that? Folic acid is the precursor for our DNA nitrogen bases, right? Our purines and our pyrimidines. And the way these antimetabolites work is they are mimics. They are mimics of the purines and pyrimidines. So when DNA goes to synthesize itself and to replicate itself, it might grab one of these fakers, one of these mimics, which then will be inserted where a normal nitrogen base was supposed to be, and will mess things up, right? And 3 big players on this list are written in red font, or appear in red font here: methotrexate, classic folic acid analog, classically used for acute lymphoblastic leukemia, fluorouracil, used for breast cancer and colon cancer, 6-mercaptopurine. The work with 6-MP and ALL has been really encouraging. I think I may have left off the session, the class last time, with a couple of words of encouragement in terms of how wonderful the progress that has been made is in anti-cancer therapy when it comes to certain types of cancers, and ALL, acute lymphoblastic leukemia, is an example. So, this business of anti-metabolites, methotrexate, all of this. So first of all, we start with folate. Folate is just the salt form of folic acid. People tend to say folic acid and folate and use them interchangeably. Understand that folic acid is the acid form, folate is the salt form, right? And so we need to ingest folate. We can't make it ourselves. Some organisms can make it, we cannot. So we ingest it or our intestinal flora make it for ourselves. You know that you are one organism, but you are host to millions and millions of organisms. As you sit here in front of me today, as I look at each one of you, I only see one organism, but I know that each one of you represents millions of organisms, and I'm talking about the microbiome. Right? So you've all heard about the microbiome, that certain parts of our body contain tons of bacteria and maybe some other microorganisms, and those bacteria do things for us. One of the things that those bacteria might possibly do for us is synthesize folate that we can then use to make DNA. Okay, so we get the folate one way or another, and it is then converted by a number of steps, famously via the action of an enzyme called dihydrofolate reductase. It is ultimately converted to these familiar friends, adenine, guanine, adenine and guanine, and thymidine, which become the building blocks of the DNA molecule. So the idea of an antimetabolite is to inhibit the dihydrofolate reductase, right? And that's exactly what methotrexate does. So methotrexate's mechanism of action that you should know is a dihydrofolate reductase inhibitor, DHFR inhibitor. So it prevents the conversion of folate to the DNA nitrogen bases. And so it becomes a very useful anti-cancer therapy because it targets cells that are busy synthesizing DNA. Once again, it is a cell cycle dependent agent, and it acts on cells in the S phase of the cycle. There is an interesting drug called leucovorin. You see here where it says leucovorin rescue. So remember, as we've been marching along, we've spoken about how some of these anti-cancer drugs have rescue agents, right? You can almost think of them as antidotes, as agents that interfere with the action of the anti-cancer drug. And leucovorin essentially blocks the action of methotrexate. Leucovorin blocks the action of methotrexate, so methotrexate can no longer do its thing, interfering with DNA synthesis. Rescue therapy for methotrexate. 5-FU is another anti-metabolite, which we will talk about, 5-fluorouracil. So it prevents the lethal effect of methotrexate on normal cells by overcoming the blockade of the dihydrofolate enzyme that normally converts folic acid to nitrogen bases. Does that make sense? So, methotrexate is toxic because it's going to target any cell that is in the process of synthesizing DNA. And we love that in terms of treating cancer cells, but of course that's going to cause hair loss, nausea and vomiting, and immunosuppression, right? And we don't love methotrexate so much when it does those things. So the antidote, if you will, to methotrexate is this leucovorin. Okay, so you know something about leucovorin. Okay, and I feel like we just had this slide. There's a cartoon showing leucovorin in action. Another anti-metabolite is 5-fluorouracil. Whereas methotrexate is a good one for ALL, acute lymphoblastic leukemia. ALL does not form solid tumors. ALL is a blood cancer. It affects immune cells that are in the circulation. 5-fluorouracil is helpful for what are called solid tumors. So colorectal cancer, breast cancer, ovarian cancer, and pancreatic cancer. And again, I am not in favor of your memorizing drug combinations. That said, a classic one is represented here. Cyclophosphamide plus methotrexate plus 5-FU for breast cancer. Now, you might ask me at this point, wait, why would you put two anti-metabolites together in one cocktail, right? If we have methotrexate there, that one is already an anti-metabolite. And the answer is that 5-FU and methotrexate, correct, they are both anti-metabolites, but they work a little bit differently. 5-FU also has an impact on RNA synthesis, methotrexate does not. So they are both anti-metabolites. They don't overlap perfectly, so that in fact they have been combined in chemotherapy drug regimens along with an alkylating agent such as cyclophosphamide. Here, that point is emphasized here. So 5-FU is complicated, it does a number of things. Whereas methotrexate is nice and clean, it's an enzyme inhibitor, it inhibits that first reaction where methotrexate is converted to products that become DNA nitrogen bases, right? But 5-FU actually has an effect both on DNA synthesis and on RNA synthesis, so it's a bit messier. But therefore it has a place in combination drug therapy that includes methotrexate. Okay, and so for each of these drugs, drug class, mechanism of action, target, something about the target, so it's good to know that methotrexate is better for acute lymphoblastic leukemia and 5-FU is better for solid tumors like breast, colon, pancreatic, ovarian, that I would know. And then, some key point about the toxicity, right? We're going to be going through, I'm not gonna lie, it's kind of a lot of drugs in this unit, isn't it? And so what I'm trying to do, first of all, provide the drug list at the end, so you know which drugs, for which drugs you're responsible, and then for each of those drugs, key facts. And when push comes to shove, the most important thing is to have drug classes in your mind, right? So we did alkylating agents, and now we're doing anti-metabolites, so really have a clear understanding of that. And then that's a starting point, so if I say methotrexate, you say anti-metabolite. If I say cyclophosphamide, you say alkylating agent. So that's the starting point. You should be able to do that like that. And then for each of those, okay, what specifics do I know? Oh yes, so 5-FU was the one that also hits RNA as well as DNA. So that's how you can sort of build your studying framework. So on that note, 5-FU causes a number of toxicities. All of these conventional chemotherapeutic agents cause the typical toxicities that conventional chemotherapeutic agents cause, right? Alopecia, nausea, vomiting, and immunosuppression, and anemia, and bleeding, thrombopenia, right? But now, 5-FU, one to remember is it causes cardiogenic shock. Okay, I don't want to get too lost in the weeds here. This is a slide dedicated to resistance mechanisms. This is a theme that seems to recur as we go through this unit. So these drugs are very nice, and they may have some efficacy for a while, but unfortunately with many of these drugs, the cancer cells are smart enough to develop resistance. So let's say a breast cancer may respond to 5-FU for a while, and then unfortunately it develops resistance, and there are different resistance mechanisms. I think it would be too much for me to say what is a drug resistance mechanism specifically for 5-FU, but I think that you should be familiar with the different mechanisms of drug resistance that we've talked about, right? We kind of talked about them a few times. Anyway, so it turns out that 5-FU is particularly affected by one type of drug resistance, which is the type where drugs are effluxed out of cells. Remember that business? ABC transporters can be upregulated after a cell is exposed to a cancer drug for some time. And in the case of 5-FU, just for your interest, the ABC transporter is MRP8, and MRP8 kicks 5-FU out of the cell, and that's how the cells manage to escape it. Overexpressed ABC ATP binding cassette, which is ABC, transporters efflux 5-FU from cells. There are other mechanisms of drug resistance specifically related to 5-FU as well. 5-FU is a pro-drug, and so there could be a decrease of the activating enzymes, and also enzymes that are necessary for 5-FU efficacy, or I should say, an enzyme that metabolizes 5-FU can be increased. Yeah.
So the 5, it's not that it's like an anti-cancer drug. It's a pro-drug or anti-cancer drug.
Correct. It's a pro-drug. So some of the drugs that we have spoken about, cyclophosphamide, if you'll recall, is actually a pro-drug, right? So loosely we say like, oh, cyclophosphamide is a cancer drug, and that it's not wrong to say that. But if you want to be really technical about it, it's a cancer pro-drug. It's not a cancer drug until it is activated in the body. Very good point. Okay. So 6-MP, 6-mercaptopurine, is another important anti-metabolite. It has found, as I say, it has found its role for acute lymphoblastic leukemia. This is a throwback slide, right? So, when we think about original modalities for treating cancer, this is where I began my discussion in this unit, and I said surgery. Surgery was the treatment up until, certainly the early part of the 20th century. Well, surgery is useless for leukemia because what are you going to cut out? There's nothing to cut out. It's a blood cancer, so the cancerous cells are in the circulation, so you don't have surgery. Radiation therapy sort of worked, but for, the leukemias were essentially one of the driving forces for the development of chemotherapeutic agents, because those cancers, we didn't have any defenses against those cancers. At least if someone had a breast cancer, it was a horrible thing, but there was some hope of cure because you could cut it out. And in the old days, surgeons would perform mastectomies and be very aggressive in cutting out the cancer. But that would work pretty well, right? And even radiation therapy, you need to have a site, a location, 1 or 2 tumor sites for applying radiation therapy. You can't really apply radiation therapy for leukemia because the leukemia goes everywhere. The cancer cells are in the circulation. So I think that, 2 things, the idea of metastatic disease, that once cancer has spread, surgery and radiation don't help as much because the cancer cells might be anywhere. And the leukemias, those were sort of the 2 driving forces that led to the development of everything that we're discussing in these couple of packets, the conventional anti-cancer drug therapy. And this agent, 6-mercaptopurine, which is an antimetabolite, it is an analog of the purines, an analog of guanine, of guanine and thymine, has had a lot of success. The 2 investigators that discovered and developed 6-mercaptopurine, Drs. Hitchings and Elion, received the Nobel Prize not that long ago, in 1988, for this discovery. It was kind of, so it's interesting, they received the prize in 1988, they discovered it in 1942. So there's often a gap between discovery and recognition, and discovery and application, right? So it was discovered in 1942, FDA approved 11 years later in 1953, and then finally the investigators, the physician investigators who discovered it and worked on it were recognized in 1988. So here's a little cartoon showing what it looks like. And as we said, it inhibits purine synthesis, so it blocks the formation of guanine and adenine, actually, guanine and adenine, and it starts in this form. You don't have to memorize the chemistry or the steps, but if you just look at it, it bears a similarity to guanine. And again, it's an anti-metabolite, so when the cancer cell goes to synthesize and replicate DNA, it grabs this mimic, and the DNA synthesis process is messed up. This is a cell cycle dependent mechanism. It's a prodrug, so cis-mercaptopurine is also considered a prodrug. It also needs to be activated. And it impacts DNA and RNA. It's incorporated into RNA. It has effects on both DNA and RNA synthesis. Really, the only type of cancer that it's used for, pretty much, I believe, are leukemias. I mean, only it's a very important type of cancer, especially for children. And so, ALL actually does have a bimodal age distribution. People think of it as a childhood cancer, and it mostly occurs in childhood. About 80% of patients with acute lymphoblastic leukemia are children, but another 20% are adults. But it's mostly a childhood cancer, as we said, S-phase specific. Here's something to remember about cis-mercaptopurine. It does have hepatotoxicity. It is toxic to the liver. And it does have its own drug-resistant mechanisms, like just about all of these drugs do. The ABC transporters are very important in drug resistance for most of the drugs that we will be discussing. So let's see if we can answer this one. An anti-metabolite drug is able to block DNA synthesis with little effect on RNA protein synthesis, and it is a single most effective agent for induction of remission in children with acute leukemia, and it has although myelosuppression is dose limiting, the drug may also cause hepatotoxicity. Cis-mercaptopurine, right? So what we were just discussing, cis-mercaptopurine. Okay, let me just see. Sorry. Moving on. So that's all that we're going to say about anti-metabolites, right? So we've talked about alkylating agents, anti-metabolites, and we're going to talk now a little bit about natural products, which include the topoisomerase inhibitors and the vinca alkaloids and taxanes. The vinca alkaloids and taxanes are antimitotic drugs. So, whereas the antimetabolites are cell cycle specific drugs that are specific to which phase? The S phase, the natural products, vinca alkaloids and taxanes, are cell cycle specific drugs that are specific to the M phase, the mitosis phase of the cell cycle. I have some slides that will allow us to dive into those a little bit more. Epipodophilotoxins like etoposide are something called topoisomerase inhibitors. We've mentioned those before. I'll explain a little bit more about what those are. Same with the camptothecans. And then we have some antibiotics that work via a number of mechanisms. There's, whereas I can tell you that the vinca alkaloids and taxanes all target tubulin, intracellular tubulin, and although they do different things to tubulin, they have that in common in terms of their mechanism. And then I can tell you that the next two types of drugs on this list target topoisomerase inhibitors. Antibiotics do a number of things, and they're sort of all over the place, but we will mention a couple of, one or two important ones, such as doxorubicin. So this is the microtubule story. Okay. So again, vinca alloys and taxanes. So the vinca alloys, such as oncovin, interfere with the assembly of the microtubules. So basically what happens in mitosis, right? So the chromosomes have to move around, right? They have to come together and then they have to pull apart during telophase and anaphase. And that whole incredibly elegant machinery works via the assembling and then disassembling of microtubules. So the vinca alloys target the assembling process, whereas the taxanes target the disassembling process. The vinca alloys mess up with the early phase of microtubule function in mitosis, whereas the taxanes actually interfere with depolymeration. At one point, the microtubules come together and polymerize, and then they need to separate so that mitosis can be completed. And it's that separation process that Taxol prevents, and the microtubules form a big mess. Yes?
Can you just repeat that one more time?
Sure. The vinca alloys interfere with the assembling part of the microtubules, whereas the taxanes interfere with the disassembling part of the microtubules. The microtubules polymerize and come together earlier in the process of mitosis, and then at the end, when the cells get ready to divide, the microtubules need to disassemble. So they polymerize and they depolymerize. The vinca alkaloids interfere with the polymerizing step, whereas the taxanes interfere with the depolymerizing step. So if you have that, that's all you need to know. And they both, however, act on the M phase of the cell cycle, and they both interfere with microtubule activity, with microtubule function, and thereby interfere with mitosis. Okay. So Taxol is a novel antimitotic agent that promotes microtubule assembly. See, the problem is that it inhibits the disassembly, so the microtubules polymerize, they stick together, and they form a big mess, and the cell cannot divide. The Taxol is a natural product that comes from the yew tree, and it was found in 1987, 23 years after its discovery, to be effective in ovarian cancer. And the scientist who is known really, I guess, for this discovery and the work on taxanes, the trade name of the major taxane is paclitaxel or Taxol, I believe is the generic name, and paclitaxel is the commercial name. And it's Dr. Susan Horwitz, who's now in her early to mid 80s over at Einstein, who worked on this. And I think I may have mentioned before she came to I had invited her to come to St. John's to give a talk a few years ago, well, pre-COVID. She gave a talk in person. So, you know, interesting fun factoid, it was isolated from the yew tree, and it has this unique mechanism of action, you know, opposite from the vinca alloys. It promotes rather than inhibits microtubule formation. And so what it inhibits is depolymeration. The microtubules become polymerized, stable, and they can't depolymerize, so they gunk up the cell. The cell cannot divide, which is, you know, a really cool, elegant way of targeting a cancer cell, isn't it? Like, you know, who would have thought, right? It promotes synthesis of the microtubules that you need to have for mitosis, but too much of a good thing is bad for the cancer cell, you know, but it promotes it too much and it prevents the depolymerization, and the microtubules just stack up and the cell cannot divide. Okay. In general, you know, just so we have an understanding, there are all sorts of nuances, but chemotherapy is generally used for metastatic disease, right? Because if you have a single solid tumor, it should be amenable to surgery or surgery plus radiation. Now, sometimes there's surgery plus radiation plus adjuvant chemotherapy to target residual micrometastases, right? But it's rare that the initial therapy, if it's a single solid tumor, it would be very rare for the initial therapy to be chemotherapy. There are, variations and things, and that could possibly be done, to shrink a tumor before surgery, but that's kind of a rare thing. So it's used for metastatic disease, famously for ovarian cancer, for metastatic ovarian cancer. Ovarian cancer is a very horrible cancer. The thing about ovarian cancer is it's difficult to diagnose early. With breast cancer, we have self-breast exams and mammograms. And when you're out there practicing, you definitely should encourage your patients to do all the prophylactic things for cancer. It's all about prophylaxis. The colonoscopies are important and they're lifesavers for colorectal cancer. Colorectal cancer is the third most common type of cancer in the United States. For breast cancer, the self-exams and the mammograms are key. For ovarian cancer, there's really nothing the patient can do, and many times when it first presents, it's already metastatic. So Taxol has been helpful for metastatic ovarian and breast cancer. Interesting factoid about Taxol. It's a radiation sensitizer. So it seems to enhance the efficacy of radiotherapy. Just keep that in mind. So when radiotherapy is used, for cancer, when it's combined with Taxol, good things happen. M-phase specific, right? We mentioned that a number of times. Does that make sense to everyone, right? Because we're targeting those microtubules that are involved in mitosis and cell division. A bunch of toxicities, bone marrow. I mean, these are toxicities that most chemotherapeutic agents have anyway, right? Immunosuppression, bone marrow, etc. There's neurotoxicity, cardio, and hepatotoxicity. And it is a substrate for a couple of those pesky ABC transporters that unfortunately kick the drug out of the cell, namely P-glycoprotein and MRP7. So that's the story about Taxol. It's, it's not perfect. People still die of metastatic ovarian and breast cancer, no question, but it has also saved lives. It's made a real dent, and it works via a particularly, I would say, elegant mechanism, almost counterintuitively, by increasing microtubule synthesis and polymeration, by doing the opposite of what the beta alkaloids do. By functioning in that way, it kills cancer cells that are in the M phase. Okay, the next type of cancer drug were the camptothecin analogs, and one is irinotecan. So this has to do with topoisomerases. So after DNA is synthesized, it's not just synthesized and done. It actually has a fancy way of coiling on itself. And that coiling is accomplished by an enzyme called topoisomerase. And so we have a bunch of drugs now that interfere with the action of topoisomerase. And that leads to unstable DNA, which can lead to cell death. This particular one, irinotecan, is also a prodrug. It is considered a cell cycle specific drug, and it is considered a drug that acts in the S phase because it does have to do with DNA synthesis. It's the later step of DNA synthesis, but it's still considered DNA synthesis. For some reason, I mean, we know that many of these drugs cause GI symptoms. We've spoken about that a lot. Usually, they're a little bit more on the nausea, vomiting side than on the diarrhea side, and for whatever reason, irinotecan causes more diarrhea, and same old business with drug resistance. Mostly these ABC transporters kick out the drug. Okay, so that's just one topoisomerase inhibitor that's in here that's mentioned. Acts on the S phase, and just so you have the general concept of topoisomerase inhibitors, cell cycle specific drugs that act on the S phase on the later stages of DNA synthesis. I think the last category, let's see how we're doing that time. Yeah, maybe, I don't know if we can finish this packet. We'll see. I think the last category of drugs, in this group of conventional chemotherapeutic drugs are antibiotics. And there are a bunch of antibiotics and they do different things. Some of them are also topoisomerase inhibitors, like the drug that we just discussed. Doxorubicin is probably the one to know about. And again, it would interfere with the topoisomerase enzyme. Now here's where things get a little hazy. These antibiotics, they do multiple things. So they might be like a topoisomerase inhibitor and there's something else at the same time. And bottom line, they generally are considered non-cell cycle specific drugs. Okay, so just remember that antibiotics are considered non-cell cycle specific drugs, with the exception of one of them, which is bleomycin. Main side effect of bleomycin that everyone should know about is pulmonary fibrosis. So bleomycin is an antibiotic that is an anti-cancer drug that has famously the toxicity of pulmonary fibrosis. And that's sort of what you need to know about that. So there are, again, various antibiotics that have been combined in combination therapy. Doxorubicin is the topoisomerase inhibitor. It also interferes with RNA synthesis. So again, it kind of does a number of things. We don't understand perfectly how it works, but it does kill cancer cells, and it's considered a non-cell cycle specific drug. Okay, non-cycle specific. It's used for acute lymphoblastic leukemia, Hodgkin's disease, which is a type of lymphoma, Wilms tumor, which is a solid tumor of the kidney, neuroblastoma, and ovarian cancer. And importantly, so the trade name of doxorubicin is adriamycin, and this is important to know. Doxorubicin has famous cardiac toxicity. So part of the protocol before administering doxorubicin to a patient is that the patient will be evaluated for cardiac function, right? So certainly an electrocardiogram will be done, but I think an echocardiogram has to be done. An echocardiogram is an imaging technique where the heart is seen in action, and things like the cardiac ejection fraction, etc., have to be evaluated. If a patient does not have adequate cardiac function, that patient is not a candidate for doxorubicin. And doxorubicin is used for a number of cancers. Breast cancer too, even though it's not listed here. It's a powerful drug with high efficacy, often combined with other drugs in combination therapy protocols, but the hurdle is the cardiac toxicity. The patient must be cleared for the use of doxorubicin, trade name adriamycin. Oh, sorry for the typo. Before we can do that. So I said it, I don't know, let's see how awake you were. Which of the following drugs can be used as a radiation sensitizer? B. Yes, good man. And I think on that note, we will take our break. Let's break for a few minutes and we'll come back and hit the last time. Okay, I apologize for that little emergency, pharmacology emergency, no, actually grant writing emergency, you don't want to know. But that's okay. We still have 20 minutes. We had a nice good break, so hopefully all of that information sunk in. And we're going to talk about targeting therapy. So I just want to take, put everything in context for a minute, right? So evolution of anti-cancer drug therapy, right? Surgery was first. Radiation therapy was second. Chemotherapy, I think we did a good job of covering chemotherapy, alkylating agents, antimetabolites, natural products, antibiotics, all of that. And that was the situation until just a couple of decades ago. Okay, there's been a revolution in anti-neoplastic drug therapy called targeting therapy. So the original rationale for drug design for cancer was based on the fact that cancer cells replicate quickly, right? They do a lot of mitosis, right? Whether or not your agent specifically is a cell cycle phase, whether or not your agent is a cell cycle phase specific agent, it's going to target cells that are replicating rapidly. That was the whole rationale for the conventional anti-cancer drug therapy. It turns out that we have learned that cancer cells have what are called oncogenes. So they have malignant versions of normal genes. We all have genes that encode things like growth factors, growth factor receptors. The problem is when those genes occur in abnormal forms, they might be overactive. A cell becomes cancerous. So the new branch of anti-cancer drug therapy, targeting therapy, takes advantage of that information. So now we're not targeting a general process of DNA synthesis and cellular replication, but if we know that a particular type of cancer has an aberrant, abnormal, mutated form of a protein that is involved in cellular growth, we are going to target that specific protein. And that's the idea of targeting therapy. So, as promised, every packet has some learning objectives. There's a lot in this packet. We'll finish it up the next time we meet, and then that will be the end of our anti-cancer drug unit, and we'll go on to the next unit. There's a lot in this packet. I have pared it down to 4 learning objectives, but obviously each of these learning objectives is pretty rich. I want you to sort of have a grasp of the difference between targeting therapy and conventional therapy, so sort of compare and contrast. So basically have an understanding of what I just said. Then the second bullet is sort of fun and a tool that I think will help you greatly as we move along and finish up this unit. And that is that there is a set way that targeting therapeutic agents are named. I'll explain what I mean by that in a minute. Name 2 major targets of these new drugs, and we'll talk about targets, things like tyrosine kinase inhibitors, angiogenesis, things like that. And then the last part that we'll get to next time will be immunotherapy. So the beginning of the development of the field of targeting therapy for cancer began in a sort of unorthodox way. There is a drug called thalidomide, which is considered a terrible drug. Thalidomide is infamous because it was used in the 1950s in pregnant women to treat morning sickness, and it did terrible things. It is teratogenic. It causes birth defects. Specifically, it causes phocomelia. I didn't bring the pictures this time, I don't think, but it caused these babies to have malformed hands and feet, or no hands and feet at all. So the drug was withdrawn from the market in the 1960s, and it was sort of stored in a black box, locked up, throw away the key. You know, nobody wanted to go near it because it had done such horrible things to so many people, to so many babies who were being carried in utero by moms who took thalidomide during their pregnancy. However, it was pulled off the shelf in 1994 and sort of re-investigated. And guess what? It turns out that it has some anti-cancer mechanisms. And the specific anti-cancer mechanism that thalidomide has is something called anti-angiogenesis. So it targets something very specific that I'm going to talk about. This is an important concept for two reasons. One, the concept of anti-angiogenesis as a mechanism of anti-cancer drug therapy is very important. Again, only emerged a few decades ago. We'll talk about it. And number two, this was sort of the beginning of the next generation of anti-cancer drug therapy, which is specifically anti-targeted drugs. So what this business of angiogenesis, another way of saying angiogenesis is neovascularization. Cancer cells and cancer tumors are really smart. They grow really quickly, and if you've ever done any pathology, or if you've ever actually seen cancer tumors, you may know that sometimes they become necrotic, they become soft. That happens because they grow so fast that they outgrow their blood supply. So they're growing so fast that the existing blood supply cannot support them. If they don't do something to increase the supply of blood nutrients and oxygens to the cancer cell, there'll be a self-limited process. They'll outgrow their blood supply, and that would be that. So, unfortunately, the cancer cells have the ability to provide their own blood supply. That's pretty wild, right? The cancer tumors have an ability to provide their own blood supplies. And the process whereby they build new blood vessels is called angiogenesis. It can also be called neovascularization. There are specific signaling molecules that control angiogenesis. The most famous one is VEGF, VEGF, vascular endothelial growth factor, VEGF, vascular endothelial growth factor. That's a really important molecule to know about, not only in the context of its being a target for thalidomide, but a little bit down the pike, other drug developers who were working on anti-cancer drug focus on VEGF as a target, and other VEGF inhibitors you will see come on the scene. So this was a new idea, right? This isn't just a general approach, let's target cells that are dividing rapidly because more or less it's the cancer cells that are dividing more rapidly than others. No, this is something specific. That these cancer cells produce their own blood supply via a process called angiogenesis, and thalidomide has specific anti-angiogenic effects by targeting VEGF. It's a little bit more complicated than that. Of course, thalidomide has other anti-cancer mechanisms as well that have to do with neutralizing free radicals, etc. But the one that is most important and sort of that I want you to know about in terms of understanding this new era in the development of anti-cancer drug therapy is the fourth point here, that thalidomide reduces angiogenesis by inhibiting VEGF. Thalidomide found its use against multiple myeloma. So I think we mentioned multiple. I think we actually, a lot of these things that I'm talking about. If you really, if you recorded me, you may hear that somewhere in the previous days of lecture, I actually in passing mentioned that thalidomide was an anti-cancer drug specifically for multiple myeloma. But as I said, repetition is the best way to learn new complex material like this. And so thalidomide is an anti-angiogenesis drug and specifically targets multiple myeloma. That's the point. Okay, so that was the beginning of the targeting era for anti-cancer drug therapy. A very important drug comes on the scene. And in fact, a very important class of drugs come on the scene, and those are the tyrosine kinase inhibitors. I'm going to say a couple words about that. So tyrosine kinases, anyone recall what they do, or kinases? Kinases are enzymes that do what? They phosphorylate other proteins, right? They add phosphate groups to other proteins, and usually when a protein becomes phosphorylated, it's activated. A tyrosine kinase just happens to add the phosphate group onto a tyrosine residue because it's a convenient place to stick a phosphate group. So now, why do I care about tyrosine kinases and tyrosine kinase inhibitors in a discussion of anti-cancer drugs? Well, if the protein that is being activated by the tyrosine kinase is a protein that is involved in cellular growth, like if it's some sort of a growth factor or growth factor receptor, that means that this tyrosine kinase is going to really drive cellular growth to the point where the cell is malignant. It's going to grow in an uncontrolled cancerous fashion. And the thing is that we all have tyrosine kinases. We all, and we all have growth factors and growth factor receptors and all of that. Here's the concept of oncogene versus gene. An oncogene is a malignant form of a gene, or a gene that encodes a malignant form of a protein. So certain cancers have tyrosine kinases that are overactive, and they activate growth factors or growth factor receptors too much. So that if you introduce a tyrosine kinase inhibitor, you will be specifically targeting, that word targeting, cells that have too much of that tyrosine kinase. So that's the idea of targeting. You introduce the tyrosine kinase inhibitor and you target cells that have an abnormal form or excess of tyrosine kinase. Now, this first tyrosine kinase inhibitor, which is imatinib, trade name Gleevec, actually was a big deal, approved rapidly by the FDA. This first kinase inhibitor targets a specific tyrosine kinase, one that's called BCR-ABL. And it's a very interesting kinase, BCR-ABL. It's formed when there is a chromosomal translocation. I'm going to flip back and forth between these two slides. What is a chromosomal translocation? A chromosomal translocation occurs when two chromosomes break and they reattach, but they don't reattach in the original configuration. So if you look here, chromosome 9 and 22 are engaged in the translocation that produces this particular tyrosine kinase, the BCR-ABL kinase. I'll say it again, chromosome 9 and 22 are the two chromosomes that are involved in the chromosomal translocation that produces BCR-ABL. How does this happen? So a break occurs, let's say over here, and this little end piece of chromosome 9 is separated from the big piece of chromosome 9. Then chromosome 22 breaks here. And so can you see that? This little part of chromosome 9 connects to this top part of chromosome 22, and you form this guy. Now, what's interesting about this guy is that it's putting genes, DNA strands, DNA segments together in a configuration that wasn't there before, right? So these two chromosomes break, right? And then they connect, but they connect in a way that the bottom part of chromosome 9 connects to the top part of chromosome 22 in a way that they were never together before, so that DNA coming from 22 hits some DNA coming from 9, and guess what? It makes a new gene. And the new gene that it makes is this BCR-ABL that does what? That encodes this nasty tyrosine kinase. This nasty tyrosine kinase, BCR-ABL, is the product of chromosome 22/9 translocation, and it's a tyrosine kinase. The chromosome translocation is called Philadelphia chromosome because it was first characterized in Philadelphia, and it's characteristic of chronic myelogenous leukemia, CML. This nasty tyrosine kinase, which is formed BCR-ABL, encodes a protein called, bless you, platelet-derived growth factor receptor and c-KIT. This is a tyrosine kinase that is abnormal and very aggressively programs the cell for growth. Okay? So, a new tyrosine kinase that doesn't exist naturally is formed by the chromosomal translocation. The drug, imatinib, targets this BCR-ABL new tyrosine kinase. It's a tyrosine kinase inhibitor, so that only the cells with the Philadelphia chromosome, with the chromosomal translocation, are affected by the drug. And cells that undergo this chromosomal translocation produce a cancer called CML, chronic myelogenous leukemia. Make sense? It's 4:49. Okay, we'll have to stop there. I apologize. I had